Hello, 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 ladies and gentlemen. I hope you are all having a wonderful holiday weekend and happy Easter to everyone. Right now, we are going to be looking at biliary and pancreatic disorders. What a way to end the holiday weekend, right? So, the class outcomes for this class, we will explain the pathophysiology of biliary dysfunction. We will discuss the diagnostics that are used to diagnose biliary disorders in in preparation for client education, We will contrast the pathophysiology, clinical manifestations, medical and nursing management of cholecystitis and acute pancreatitis. We will describe the pathophysiology of pancreatic dysfunction and the diagnostic studies used to identify the pathology. And because we are nurses, we are going to formulate a nursing plan of care for a client that is diagnosed with cholecystitis. So let's talk about the biliary system. The biliary system will include the gallbladder and the bile ducts, the cystic duct, the duct from the gallbladder, and the hepatic duct, which is coming from the liver. They will join to form the common bile duct. So now if you, in my folder, there are some videos if you need a refresher on the anatomy and physiology of the biliary system. So bile is a digestive enzyme that will help to break down the fats. Biliary disease will occur when the gallbladder or the ducts become inflamed, infected, or cancerous, impairing the ability of the gallbladder to function normally. So, cholecystitis, how does this happen? The inflammation of the gallbladder is caused by an obstruction of bile flow and is classified as either calculous cholecystitis, and this means that there is also the presence of gallstones, or acalculous cholecystitis, and this means that there are no stones present. Gallstones are hard deposits that are formed from bile contents that often cause obstruction in and around the gallbladder. So the incidence of gallstones and cholelithiasis will increase with age, with gallstones more common in women than in men, and this is because of our hormones. So, ladies and gentlemen, listen up, and then listen up one more time. One approach to remembering signs and symptoms that are associated with gallstones is what we call the 5 F's. The 5 F's, meaning fair, as in light skinned, fat, as in overweight or obese, you are female, you are fertile, meaning that you are in your childbearing years, and if you are over 40 years of age. So in that instance, I guess childbearing age doesn't really make a difference, right? So risk factors for gallstones will include obesity or rapid weight loss. If you have had weight loss surgery, eating large amounts of foods that have saturated fats, and then pregnancy. And this is because of the elevated progesterone levels. So many times, the first time a female will have a gallbladder attack is during her pregnancy. And it is not uncommon, either sometime during the pregnancy if the gallbladder is incredibly diseased, or shortly after the patient gives birth, that the gallbladder will be removed. Now, sometimes they will only have a gallbladder attack once during their pregnancy, and then as soon as the baby comes and they have delivered, well, of course, the progesterone levels are decreased, and so she may never have a gallbladder attack again. Genetics will also play a part, and then medications. Estrogen and cholesterol lowering medications will contribute to cholecystitis. So the pathophysiology of cholecystitis. Gallstones are hard deposits that will form in the gallbladder and are generally classified into 3 categories. Excuse me, I'm so sorry. Cholesterol stones, which are the most common type. What we call pigmented, and this is formed from excess bilirubin. And then we have mixed, and this is a combination of both stones, the cholesterol stones and the pigmented. These stones can vary in size. They can be very small, such as small as a pea, or they can be very large, as in the size of a softball. Most commonly found blocking the cystic duct or the common bile duct, and so we call this choleductolithiasis. Acalculous cholelithiasis, is associated with biliary stasis, where there is a slowing or stopping of the flow of bile, either from decreased contractility of the gallbladder or spasms in the sphincter of Oddi. Patients with non-complicated cholecystitis that are related to gallstones will recover within 1 to 4 days after the onset of clinical manifestations. And then complications such as perforation or gangrene can then lead to critical illness, and that would be sepsis because it would be a systemic infection. So some clinical manifestations of cholecystitis. The clinical presentation of acute cholecystitis includes pain and tenderness in the right upper quadrant, and this is due to the release of what we call cholecystokinin. And this is a hormone that will cause the gallbladder to contract. So after this is released, this cholecystokinin, what the patient will develop is what we term colicky pain. And colicky pain is intermittent. It will come and go. It comes very suddenly, so the patient is just resting. And then all of a sudden, in the next moment, they're in horrible pain. They may be in pain for a few seconds. They may be in pain for a few minutes. They may be in pain for a little longer than a few minutes. And then all of a sudden, the pain will go away. So it is intermittent, and it will radiate to the back. And this is related to the movement of the gallstones through the bile ducts as the bile flows. So, such as with kidney stones, which we will talk about in a bit, the only time this patient will have pain is when those stones are moving. If the stone is stationary, there is no pain. Rebound tenderness or guarding is another clinical manifestation. Fever and tachycardia. So, ladies and gentlemen, listen up, and then listen up one more time. There will be a palpable fullness of the right upper quadrant. And also, there will be what we call a positive Murphy sign. A positive Murphy sign is pain on palpation of the right upper quadrant upon deep inspiration. So the belly will feel full. There will be a fullness around that right side, that right upper quadrant. And then when we are assessing our patient, they will be positive for this Murphy sign, pain on palpation of the right upper quadrant upon deep inspiration. And then your patient may also have jaundice, and this is because of impaired bile flow. So this medical management, how was this diagnosed? There are several different tests that are utilized to determine the presence of gallstones. So it is important for the nurse to be aware of patient allergies to iodine or radiopaque substances because these may be used for some of the procedures. So if the patient is going down for a scan, or if the patient is going for a test that is going to illuminate the belly, they're going to be injected with a dye, a radio dye, an iodine dye. And so if the patient is allergic to shellfish or iodine, it is very important that we know this because there will be a prep that doctor may order, and that prep is Benadryl and a steroid. Abdominal X-ray is used to detect calcified gallstones. Abdominal ultrasound is a non-invasive test that is used to determine the presence of gallstones and acute cholecystitis. So CT scans will visualize the entire abdomen and can detect the presence of gallstones. Hepatobiliary immunodiacetic acid, otherwise known as a HIDA scan, is a nuclear medicine scan that will use this radioactive tracer to study the production and flow of bile, visualizing the liver, the gallbladder, the bile ducts, and the small intestine. So again, this would be one of those scans, one of those diagnostic studies that doctor may order. And so if the patient is allergic to iodine, then it is very important that we know that, so that they may have to receive that PrEP, the Benadryl, the antihistamine, or the steroid. ERCP will allow visualization of the common bile duct where gallstones can be removed. After the ERCP, the patient will go to the post-anesthesia care unit, the PACU, to allow time for recovery from the sedation because they will be sedated for this procedure. So it is important for the nurse to observe the patient after the ERCP for a potential systemic inflammatory response syndrome, and we call this SIRS, S-I-R-S. And this is caused by the manipulation of the bile ducts and potential bacterial translocation. And so what happens is during the ERCP, when the physician is using the scope, if there is any bacteria that is along the wall, or if any bacteria is in the duct or in the gallbladder, that bacteria can be moved and it will travel. And this is what causes the inflammatory response syndrome. So after the ERCP, the patient needs to be monitored. Cholecystography is a diagnostic procedure that is a radiographic test of the gallbladder after the patient orally takes radiopaque dye, which will collect in the gallbladder and is excreted by the liver. So again, it is necessary that the nurse talk with the patient about anything that they're allergic to. Cholangiogram is used in the operating room to image the biliary tree. So if the patient has to go to surgery to have their gallbladder removed, something that doctor can do is a cholangiogram. And again, he is going to inject a dye while the patient is in the in the operating room to illuminate the biliary tree so that he can see. Diagnostic studies used in the diagnosis will include a complete blood count and then liver function tests. Some significant findings will include an elevated WBC count due to inflammation, and then elevated liver enzymes, including AST, ALT, and lactate. Something that we call LDH and ALP, as well as bilirubin, because of the blockage of the bile flow in the bile ducts. So again, those elevated liver enzymes will include AST, ALT, something that we call LDH, and then ALP. All of these are liver enzymes. And then we are also going to be looking at the bilirubin, because if there is a blockage in the bile flow, these liver enzymes will be elevated. So what is the treatment? The treatment for cholecystitis. Lithotripsy. Lithotripsy is extracorporeal shockwave therapy, and this is commonly used to dissolve gallstones. This modality is used in conjunction with oral agents to help dissolve the gallstones. So lithotripsy can be used for the treatment of smaller gallstones. But ladies and gentlemen, listen up, and then listen up one more time, and please take note of this. The preferred method of intervention for gallstones is a laparoscopic surgery, and we call this a laparoscopic cholecystectomy, and this is now the preferred method of intervention for somebody with gallstones. Previously, it had been lithotripsy. Now, evidence has shown us that no, surgeons and physicians are now choosing a laparoscopic cholecystectomy over the lithotripsy. So some medications for cholecystitis. Treatment will include nothing by mouth, meaning that the patient will NPO, and there is a lot of reason for this, and that is because when the patient is NPO, there is no cholecystokinin that is released, and it is that cholecystokinin, that hormone, that is going to cause us pain. So once the patient is NPO, nothing to eat or drink by mouth, that hormone is not secreted, and so they begin to feel better. But once they begin to feel better and that pain goes away, now again they will want to eat. So IV hydration, because they are NPO, correction of fluid and electrolyte imbalances, so we're going to be looking at those labs, pain management, IV antibiotics as indicated. And so if we are using an antibiotic, if doctor is going to use an antibiotic, the use of antibiotics is a short course with a broad spectrum medication. I'm really not going to name a medication because there are several that are broad spectrum, and it will really be the physician's choice. So patients are going to be NPO to prevent the release of cholecystokinin, as we said, which is activated after eating and then will cause the gallbladder to contract and then release bile. And it is this release of bile that gives us the pain. Morphine is contraindicated for pain management as it can cause the sphincter of Oddi to spasm, resulting in pain. So this is what happens. The patient is going to eat. There is going to be that release of cholecystokinin, and so the gallbladder is going to contract, which is going to cause us pain. Now, morphine is going to do the same thing. It is going to cause this contraction. So that is why morphine would not be a medication of choice for somebody who is in the throes of a gallbladder attack. So there's a very old medication called Demerol that physicians used to use in place of morphine. Now Demerol is not so widely used, and so currently the medication of choice is Dilaudid for severe pain. So acetaminophen or non-steroidal medications such as ibuprofen or naproxen can also be used for pain management in patients that have less severe pain. Oral agents are used to dissolve gallstones. So these natural bile acids are used to reduce the size and then the number of gallstones. So effective medications will include Ursodol and Actigol. These will work best in small-sized stones with a high cholesterol content because it's going to work on breaking down that fat. Patients may need to take these medications for up to 2 years. So we really need to get the patient to buy into this treatment plan because they are going to be on these medications for 2 years in order to dissolve the stones. So in a patient who may or may not be so compliant, this may not be the treatment of choice for them. This intervention is dependent on the presentation of the patient and the severity of the clinical manifestations. Standard surgical treatment is a laparoscopic cholecystectomy. So if it is if the patient is very, very ill or doctor knows that the gallbladder is very diseased or very inflamed, then yes, we are going to surgically remove it. If the patient has complications such as a perforated gallbladder or peritonitis, an open surgical procedure may be indicated. So again, ladies and gentlemen, please remember that the method of choice, the treatment of choice, is that laparoscopic cholecystectomy. And it is only if doctor cannot do that that he will do an open surgical procedure. Open cholecystectomy may be indicated if the patient has a history of previous abdominal surgeries or is morbidly obese. Previous abdominal surgeries because there may be scar tissue in the belly and doctor may not be able to maneuver around that scar tissue with in order to do a lap chole, excuse me. So ladies and gentlemen, please listen up, and then listen up one more time for me. If stones are present in the common bile duct, surgeons may place what we call a T-tube, and this is a biliary drainage tube, and this is going to go into the common bile duct, and this is what we are going to use to monitor bile drainage because it's going to take a bit of time for the body to realize that the gallbladder has been removed. So there is still going to be that production of bile. Laparoscopic cholecystectomy will use several small incisions in the abdominal cavity. So during the immediate post-op period, the patient will recover from anesthesia in the PECU, and the nurse is going to monitor vital signs, pain. We are going to monitor their neurological status because they have had anesthesia. We are going to monitor for nausea and vomiting. We are going to be looking and monitoring the surgical site for distension. We are looking for bleeding. We are looking for bruising. Now, if the patient had a lap chole using laparoscopy, some bruising is expected. Please note that. Once the patient is awake and following commands, they may have clear liquids, only in small amounts. After the first 12 hours of liquids, and if the patient is not nauseous, if they are not vomiting, there is no abdominal cramping, patients can gradually introduce small amounts of solid foods, and then they can maintain a low-fat diet. It is important to teach the patient that it is okay to take a shower after the first 48 hours and get the incision wet. However, ladies and gentlemen, please note, patients should not let the water pressure flow directly on the incision. So what we are going to educate the patient to do is to face away from the shower. So their back is going to be toward the shower head, and the water will just fall down the front of their body, but the water pressure will be on their back. So we don't want the water pressure to flow directly onto the incision. This will increase the chance of infection at the incision site. And so also, ladies and gentlemen, what we're going to instruct the patient to do is whatever towel they're using to dry off on the rest of their body, they are not to use that same towel on their belly. Because even though the staph that is on the top of their body, and we all have staph, right? We know this. But we don't want that staph to come near the surgical incisions. So ladies and gentlemen, please listen up, and then listen up one more time for me. So we need to educate the patient on the post-op care of this T-tube. And so not only the patient, but until the patient goes home, the nurse is going to assess the characteristics of the drainage, color, consistency, and amount. We are going to empty the contents of the drainage bag when it is about half full to 2/3 full. And it is very important to educate the patient if they go home with this T-tube on doing this, because as the drainage is going into the bag, if the bag gets too heavy, it's going to pull on the incision site. We are going to talk about skincare with them, and I know that the textbook says that we can flush this T-tube as necessary. I have never had to flush a T-tube, and I've never educated a patient on how to. Open cholecystectomy is the removal of the gallbladder through an open incision in the abdomen and is performed under general anesthesia. Post-op care will include monitoring vital signs, monitoring their pain, their neurological status, and then assessing the abdomen for signs and symptoms of distension, bleeding, or bruising as well. So, we are nurses, and as nurses, we are going to assess. So the most common symptom that your patient is going to present with is abdominal pain. So we are going to be monitoring their pain. Physical exam will include right upper quadrant tenderness, fever, and an elevated heart rate because of the fever. The patient may have a positive Murphy sign. Patients also have elevated liver enzymes, bilirubin, and WBC because of obstruction and inflammation. Vital signs we're going to assess because of fever and tachycardia. This can represent inflammation due to the gallstones. Serum electrolytes, these imbalanced electrolytes are due to dehydration from nausea and vomiting and lack of oral intake. An elevated BUN and creatinine may be noted. Serum WBC, inflammation will lead to an elevated WBC count, And again, those liver enzymes, the bilirubin, and then the AST, the ALT, the LDH, the ALP, all of those, as well as the bilirubin, are going to be elevated due to the obstruction of the bile duct. We're going to monitor the skin turgor. It will be decreased. This can indicate dehydration. We're going to monitor pain, onset, duration, exacerbating, and relief factors. This can be intermittent and colicky. Colicky, again, remember, it starts and stops abruptly. And then the abdominal assessment, distension, bowel sounds, Murphy sign. And again, that Murphy sign palpation may reveal rebound tenderness, muscle guarding, or a rigid abdominal muscle due to the patient's pain. And then we are going to monitor their stool, or we're going to ask the patient about their stool, because there is something called steataturia, and this is the presence of excess fat in the stool, or the stool will look oily, clay-colored, and this is due to the blockage of bile flow. We're going to put the patient on daily weight. This will provide information regarding fluid gains or losses. Intake and output. This will provide data about fluid volume status and prevent dehydration. And then we are going to monitor their nutritional intake. And we are going to look at their diet history, their fat intake, and that foods that can contribute to their symptoms. So some nursing actions for cholecystitis. We are going to maintain an MPO status. We're going to administer ordered antibiotics, administer ordered bile acid reducers, administer analgesics as ordered, administer antiemetics as ordered. We're going to promote bed rest. We can put the patient in a semi-Fowler's position that will keep them comfortable. And then if the patient has a nasogastric tube, it will be to low intermittent suction. And then patient education for cholecystitis. Postoperative instructions. Discharge education will include signs and symptoms of infection, prevention of constipation, a low-fat diet, and activity restrictions. So we are going to encourage walking and then normal activity within a week, such as driving, working, and light lifting, anything that is less than 10 pounds. So the equivalent of a gallon of milk. Not that I think that a gallon of milk is about 10 pounds, but that is usually the standard of that we use because patients can relate to that. And no driving while taking narcotics. T-tube management, the patient needs to monitor the insertion site for inflammation and drainage. And then again, the patient needs to be instructed to empty the T-tube bag when it is about half full, 2/3 full, so that it doesn't pull on the insertion site. The patient should avoid a diet high in saturated fats. And then we should educate them on disease, clinical manifestations, the progression, and diagnostic procedures and interventions. And then how do I know? How do I know that I've done a good job taking care of this patient with cholecystitis? Cholecystitis is a manageable disease process. It is important to educate patients about this disease and its clinical manifestations and help them develop a plan for prevention. Timely and accurate diagnosis will facilitate definitive treatment that focuses on pain management and medical surgical management. And so moving on to acute pancreatitis. How does this happen? This is a disease that is characterized by inflammation of the pancreas and is classified as acute or chronic. So acute pancreatitis, the patient will present with life-threatening conditions that require hospitalization, and usually this patient will be in the ICU. It is inflammation of the pancreas that can be mild to severe, and it will affect all ages. In a mild case, there is no end organ dysfunction. It is self-limiting. It will happen once, and then it will go away. If it is severe, Again, the patient may develop that SIRS, that systemic inflammatory response syndrome, and end organ dysfunction. Acute pancreatitis is more frequent in males than in females. Chronic pancreatitis, this is a persistent inflammation that will cause scarring and damage to the pancreas and surrounding tissue. The most prevalent causes of acute pancreatitis are gallstones and alcohol. So remember that the gallbladder and the pancreas, they're neighbors, right? They're friends and they're neighbors. So if there's inflammation in the belly, if there's inflammation in the gallbladder, for instance, well, the pancreas may also be inflamed. Gallstone pancreatitis is due to the presence of gallstones obstructing the bile duct or located near the area where the bile duct and the pancreatic duct will empty into the duodenum, causing alteration in the flow of bile and pancreatic enzymes and leading to inflammation of the pancreas. Gallstone pancreatitis is more common in women than men, and this is because of our hormones, and incidence increases with every decade of life. So acute pancreatitis is a reversible process involving inflammation of the pancreas secondary to the release of pancreatic enzymes that will auto-digest. And so when we're talking about autodigestion, what this means is that the pancreatic enzymes will begin to eat away at the pancreas and then surrounding tissue. So acute pancreatitis may occur as an isolated event, or it can be recurrent. And it has a variety of causes ranging in severity from mild to severe. And again, it can be life-threatening if they develop SIRS. So some clinical manifestations of acute pancreatitis. Patients will present with sudden onset of epigastric pain that is felt in the upper left quadrant and mid-abdomen and can radiate to the back or the shoulder blades. Pain will be characterized as being deep and very sharp and becomes more intense with eating foods that are high in fat content. So instead of pancreatitis, the patient may actually think that they are having a gallbladder attack. Pain can be constant and severe, and it can last for several days. The pain will be severe when the patient is lying flat or if they are bending forward. The pain is associated with nausea, vomiting, and then anorexia meaning loss of appetite. Other clinical presentation will include abdominal fullness from gas or bloating. My patient may have hiccups. They may complain of indigestion. They may have a fever, tachycardia, hypotension. So, how is this diagnosed? What will doctor do? Physical examination will reveal a tender abdomen with localized guarding and rebound tenderness. So, we can also look for the presence of a Cullen sign. And a Cullen sign is bruising. It's going to look like bruising. It's actually hemorrhaging under the skin. But the reason that the way that I am able to remember it is that the Cullen sign will only form halfway around the umbilicus. And so that's how I remember it, because going halfway around the umbilicus, it looks like a C. So that is the Cullen sign. And then there is Gray-Turner's syndrome. And so Gray-Turner's syndrome is bruising on the flank. And the way that I remember that is when I am turning my patient and I see that bruising on either their right or their left flank, then I know that, again, they are hemorrhaging underneath the skin. That's what causes the bruising. But because I noticed it when I was turning them, I associate that with Gray-Turner's syndrome. So Gray-Turner's and Cullen signs can take 24 to 48 hours to develop. And it can be a predictor of acute pancreatitis with pancreatic necrosis and retroperitoneal or intra-abdominal bleeding, because you will see that hemorrhaging under the skin. It will look like a bruise. Laboratory test that is used to diagnose acute pancreatitis. Doctor will do a metabolic panel, hematology studies, and then some specific tests of pancreatic enzymes such as serum amylase and serum lipase. So amylase is an enzyme that aids in the digestion of carbohydrates, and lipase is the enzyme that will aid in the digestion of fats. And we can see an elevated BUN, AST, ALT, and a WBC. So, ladies and gentlemen, please listen up, and then listen up one more time. An elevated BUN will indicate impaired kidney functioning, suggesting hypovolemia. So now just remember that hypovolemia is just a fancy name for dehydration. So when you see that BUN going up, when you see that creatinine level going up, then you will know that your patient is dehydrated. They are hypovolemic. Elevated AST will indicate damage to the liver cells, and elevated ALT is indicative of gallstone pancreatitis. Elevated serum lipase is the most specific test for pancreatitis because lipase is produced only by the pancreas. Decreased serum albumin will be related to inadequate nutrition, and I cannot say this enough. Once you see that albumin level and it is not within the norm, then you can assume that your patient is malnourished. So, patients with gallstone pancreatitis will have elevated serum, bilirubin, serum amylase, and serum liver enzymes, that AST, ALT, ALP, LDH, and this is all related to gallstones obstructing the bile flow. Elevated WBC is an indicator of inflammation, and again, some diagnostic testing will include abdominal CT scans, an MRI, and abdominal ultrasound. These diagnostic tests will evaluate for the presence of an inflamed pancreas, gallstones, and the bile duct obstruction or distension. There are several scoring systems to determine the severity of pancreatitis. There are 4. The most commonly used is the Ransom's criteria, and this is a means to measure the severity of illness and the likelihood of mortality in patients. So, the patient is evaluated upon admission, and then again within the first 48 hours according to the scoring criteria. If at 48 hours the patient has a score of greater than or equal to 3, then severe pancreatitis is unlikely. The higher the overall score, the higher the mortality rate. And then CTs with contrast is the standard for the diagnosis of pancreatic necrosis or fluid collections around the pancreas. And this is also used in scoring the severity of pancreatitis. So the treatment for acute pancreatitis. Specific interventions for the treatment of acute pancreatitis will include NPO status to prevent the release of these pancreatic enzymes that is responsible for the autodigestion of the pancreas. Remember, by making the patient NPO, we are quieting the belly. IV hydration and pain medications. Severe acute pancreatitis with end organ involvement, meaning the heart, the lungs, and the kidney. The patient needs to be managed in the ICU because of the potential for hypovolemic shock, pulmonary compromise, renal failure, and GI bleeding. If the patient has necrotic pancreatitis, IV antibiotics are indicated. If the pancreatitis is caused by gallstones, the patient will undergo a cholecystectomy. The specific cause of pancreatitis, whether it's biliary obstruction, alcohol, will determine the medical management. Endoscopic sphincterectomy to dislodge gallstones may be performed as an alternative. If pancreatitis is alcohol-induced, it is important to monitor and treat the patient for alcohol withdrawal. Treatment would include sedation, hydration, and nutrition. So some medications for acute pancreatitis. Medications that are used for treatment will include opioids for pain, anticholinergics to decrease secretions, histamine blockers, pancreatic enzymes, and then antibiotic therapy. So on page 1484, table 60.3, medications used in the treatment of acute pancreatitis. Ladies and gentlemen, please listen up, and then listen up one more time. Please know that table. Diet for acute pancreatitis. Patients with severe acute pancreatitis are managed with IV fluids and parenteral nutrition. Patients with mild forms of acute pancreatitis will begin oral intake within a few days of their first onset of pain, and they do not require parenteral nutrition. So, some complications of acute pancreatitis. Necrotic pancreatitis may present after 1 week after the onset of acute pancreatitis, and it is diagnosed by a CT scan. The patient may develop sepsis, shock, and then multiple organ failure. There are 2 types of pancreatic necrosis: sterile and infected. Sterile pancreatic necrosis describes areas of necrosis that are free of bacteria, so that it only stands to reason that infected pancreatic necrosis will relate to necrosis that is caused by a bacteria. Pancreatic hemorrhage is a rare complication that occurs in 1 to 3% of patients with acute pancreatitis as a result of pancreatic enzymes causing micro rupture of the vascular system surrounding the pancreatic bed, and this is also due to the autodigestion of the pancreas. Patients will experience increased pain, decreased blood pressure, and an elevated heart rate. Abdominal examination can reveal Gray-Turner sign or Cullen's sign. Pancreatic pseudocysts are encapsulated areas of fluid that will contain pancreatic enzymes and pancreatic tissue. So if a pseudocyst becomes infected, it is known as an abscess, and the patient requires either percutaneous drainage or a necrosectomy, and this is the excision of the necrotic tissue. And this is done to drain or debride the infected fluid collection and the surrounding tissue. Patients with infected pseudocysts will present with chills, fever, nausea, vomiting, and abdominal pain. A pleural effusion is the abnormal accumulation of fluid between the layers of the pleura in the lung and can occur in pancreatitis because of impaired capillary permeability or inflammation. So patients will complain of shortness of breath, they will complain of hiccups, or pleuritic chest pain. So, nursing management of somebody with acute pancreatitis. What are we going to do? We are nurses, so we are going to assess. The classic presentation of acute pancreatitis is this sudden onset of acute, unbearable pain. Other clinical manifestations will include an elevated heart rate and a respiratory rate that is elevated and low blood pressure. Pain, elevated serum lipase, amylase, and glucose levels, hypocalcemia, steatorrhea, those clay-colored stools, hypovolemia, hypoxia, pleural effusion. Clinical manifestations of acute respiratory distress syndrome, otherwise known as ARDS, multiple organ dysfunction, Abnormal vital signs such as tachycardia and hypotension due to intravascular volume depletion. So some nursing interventions for acute pancreatitis. We are going to assess vital signs. Fever and tachycardia may represent inflammation. We're going to monitor the oxygen status. The patient's oxygen level may be decreased because of alveoli collapse and pleural effusion. Pain, the location, intensity, and duration. Pain located in the right upper quadrant is the head of the pancreas, or left upper quadrant, that is the tail of the pancreas, is related to the autodigestion of the pancreas. Abdominal assessment, palpation may reveal rebound tenderness, muscle guarding, or rigid abdominal muscles. And then gray Turner's and or colon signs. Again, gray Turner's sign is bruising noted on the flank due to the leak of exudates stained with blood. Colon sign will be the bruising around the umbilicus. Remember, only half of the umbilicus, so it'll look like a C. Serum lipase and amylase due to inflammation of the pancreas. Serum glucose due to the digestion of the pancreas. Serum calcium assessed for neuromuscular irritability when calcium levels are low because of the accumulation of fatty acids. So we're going to look at the stool color. This can be clay colored due to the obstruction of bile flow. Nutritional intake, patients will exhibit loss of appetite due to their pain. And then daily weight, monitoring of fluid intake and output to prevent dehydration. Some nursing actions for acute pancreatitis. We are going to maintain NPO status. If the patient has an NG tube, it will be to low suction. We can administer ordered medications, administer analgesics, administer antiemetics, administer histamine blockers, administer sedatives and anti-anxiety medications. Promote bed rest. The patient can be in a semi-Fowler's position, and then encourage coughing and deep breathing. So some patient education for acute pancreatitis. Appropriate diet and intake of small frequent meals and vitamin supplements. A diet history can help identify foods that can contribute to this patient's symptoms. Abstain from alcohol. Abstain from smoking, associated with pancreatic cancer and with interfering with the healing needed by the pancreas. Disease symptoms, the progression, diagnostic procedures, and interventions. And then how do I know? How do I know that I've done a good job taking care of this patient with acute pancreatitis? Acute pancreatitis is a serious, often life-threatening disorder that will require vigilant nursing management. Monitoring those lab studies is a priority for evaluating the effectiveness of the treatment plan. Pain management and nutritional status are indicators of how the disease is progressing. Positive outcomes will include stable vital signs, a stable weight, serum electrolytes within normal limits, decreased pain, and decreased liver enzymes. So we've talked about acute pancreatitis, so now let's talk about chronic pancreatitis. So how does this happen? Well, the most common cause is heavy alcohol use. It is commonly diagnosed between the ages of 30 and 40, and it is more common in men than women. However, prevalence will increase with age. And one of the primary differences between acute and chronic pancreatitis is that the chronic form is not reversible. The chronic form is not reversible. So on page 1488, box 60.4, causes of chronic pancreatitis, ladies and gentlemen, you will take note of that box. So, chronic pancreatitis is an inflammation of the pancreas that occurs when digestive enzymes will auto-digest the pancreas, same as in acute pancreatitis, and surrounding tissues for a prolonged period of time. Because of inflammation and scarring, the pancreas is unable to make the digestive enzymes necessary for the digestion of fats and their proteins. So the clinical manifestations will be upper abdominal pain, which can spread to the back, and it will feel worse after eating or drinking. So again, if this is the patient's first pancreatic attack, which I doubt if it's chronic pancreatitis, but many times they will confuse pancreatic pain for gallbladder pain because it will present the same way. Pain is often constant and will prevent the patient from participating in normal daily activities and is often described as recurring epigastric and left upper quadrant pain. Pain will be exacerbated by alcohol consumption and overeating. So that's a clue for this population. Clinical manifestations will also include nausea, vomiting, weight loss. Pancreas is no longer secreting those pancreatic enzymes to digest the foods, leading to decreased absorption of the nutrients, and then the patient is malnourished. It has inadequate nutrition. Diarrhea, the pale or clay-colored stools, or their stools may be oily. Diagnostic workup will include abdominal CT, ultrasound, or an ERCP to visualize the pancreas and verify obstructive changes. Diagnostic tests will also include amylase and lipase levels, serum alkaline phosphatase and bilirubin levels, and serum glucose levels. So the treatment of chronic pancreatitis will include pain management, IV fluid replacement, electrolyte management, nutritional support, insulin therapy, and then pancreatic enzyme replacement therapy, otherwise known as PERT. And these are used to treat the malnutrition and the malabsorption. And this patient, more often than not, is cared for in the ICU. So GI prophylaxis and histamine blockers or proton pump inhibitors, total parenteral nutrition, and patient education to modify the risk factors of heavy tobacco use and alcohol consumption. So surgical management of chronic pancreatitis in some patients, surgical resection may provide symptomatic relief of pain. Laparoscopic draining may be indicated in patients with abscesses or pseudocysts. And because of the irreversible nature of chronic pancreatitis, surgical procedures will address issues related to pain, inflammation, and obstruction, and these are not curative. So, nursing management of this patient. Chronic pancreatitis is characterized by pain and weight loss and is an irreversible disease process. Remember, irreversible. Constant burning pain that is characterized by exacerbations of intense, unrelating pain and anorexia, nausea and vomiting, constipation, flatulence, and then steatorrhea, fatty stools. Elevated amylase, lipase, serum bilirubin, and alkaline phosphatase, and an elevated blood glucose level. So some nursing interventions for chronic pancreatitis. We are going to assess, because we are nurses, we're going to assess vital signs. We're going to look at the pulse rate, the respiratory rate, and blood pressure elevations are associated with episodes of pain exacerbation. Serum blood glucose levels, and this is due to the decreased insulin production. Amylase and lipase levels, serum bilirubin and alkaline phosphatase, obstruction of bile ducts leading to an increase. And then we are going to monitor their weight, because there is malabsorption syndrome. Pain, this will be secondary to the inflammation and obstruction. We're going to assess the abdomen. Tenderness will be observed. Skin color, jaundice may be observed with obstruction of the bile ducts. And then the stool. Steatorrhea may develop as well as clay-colored stools due to bile obstruction. So, some nursing actions for chronic pancreatitis. We are going to administer those pancreatic enzymes that PERT. These medications will contain amylase, lipase, and protease to enhance the absorption of nutrients. We are going to provide GI prophylaxis, histamine blockers or proton pump inhibitors to treat the increased gastric acid secretions. We are going to provide rest and a calm environment. This will decrease the strain on the pancreas. We are going to implement pain relief measures and then collaboration with the dietitian to ensure adequate nutrition. This may require increased caloric intake or parenteral nutrition as a result of alterations in absorption. And again, these alterations can be seen in their serum albumin level. So, ladies and gentlemen, please listen up, and then listen up one more time. Patient education for chronic pancreatitis. We are going to educate the patient to avoid alcohol. This will exacerbate the dysfunction of the pancreas. Do not chew pancreatic enzymes. Limit fat in the diet. Avoid intake of irritating foods, beverages such as coffee, caffeine. This will increase their gastric distress. And if necessary, referral to a support group such as Alcoholics Anonymous or Al-Anon, because this is a progressive, irreversible disease. So, evaluating care for this patient with chronic pancreatitis. How do I know? How do I know that I've done a good job? Effectiveness of disease management is related to pain management and minimizing weight loss, secondary to the administration of opioid and non-opioid medications. A decrease in steatorrhea is associated with the actions of pancreatic enzyme replacement, and then the patient and the family are involved because this is important in minimizing exacerbations by avoiding alcohol intake and seeking out support groups. So, now moving on to pancreatic cancer. How does this happen? There is no reliable screening test for the early detection of pancreatic cancer. Clinical manifestations are vague and similar to other GI disorders, so we're not going to know until sometimes it is really too late. Majority are adenocarcinomas. These are malignant tumors that will grow on the epithelial cells of the organ, and they develop in the exocrine portion of the pancreas. Most common is the ductal adenocarcinoma that is found in the head of the pancreas. So there is a high association with cigarette smoking, diets that are high in fat, consumption of meat, fried foods, refined sugars, and nitrates. In diabetes, in patients with chronic pancreatitis, if there is a family history of pancreatic cancer, and risk will increase with age. It is very common over the age of 60. The pathophysiology of pancreatic cancer. Tumors may be primary or metastatic. Usually originates in the lung, breast, the thyroid, the kidneys, or the skin. May metastasize to the stomach, the duodenum, the gallbladder, and the intestine. Cancer that invades the tail and body of the pancreas may metastasize to the liver via the splenic vein. The patient will present with an abdominal mass and hepatomegaly. So, some clinical manifestations of pancreatic cancer. Clinical presentation is directly related to the degree of pancreatic damage that is secondary to the tumor growth. Pain will be described as a dull ache in the epigastric area and in the back. There may be some jaundice, and this is associated with obstruction of the bile duct. The patient is fatigued, and they have weight loss. So, how is this diagnosed? The clinical evaluation will include ultrasound, CT scan, MRI, and/or an ERCP to determine the presence of a mass. Definitive diagnosis is through a histopathology, angiography to determine the involvement of vessels surrounding the pancreas. So some laboratory values of pancreatic cancer. There is no single blood test available for early diagnosis. Several lab values may be abnormal. An elevated amylase, elevated total and direct bilirubin, elevated liver enzymes, fecal fat, trypsin. Trypsin is an enzyme that will aid in the digestion of protein. And lipase will indicate how the pancreas is functioning and the need for pancreatic enzyme supplementation. So, treatment for pancreatic cancer recommendation is combined chemotherapy and radiation. External beam radiation over a 6-week period concurrent with 5-FU chemotherapy for up to 4 months helps to improve long-term survival. So, ladies and gentlemen, listen up, and then listen up one more time. Surgical management of pancreatic cancer. The stage of the cancer and the location of the tumor will determine whether surgical intervention is an option. Surgical resection is potentially curable. However, if there is lymph node involvement, the cancer is unresectable. Please take note. If there is lymph node involvement, the cancer is unresectable. Patients may have to undergo surgery to relieve symptoms, and this is a palliative surgery. I am not going to fix anything. I am not going to cure anything. This is simply for comfort. And then a celiac nerve block can be performed to decrease the pain that is associated with compression of the celiac nerves surrounding the aorta. So if the tumor is located on the head, the neck, or uncinate of the pancreas, the patient can undergo the Whipple procedure or pancreatoduodenectomy. If the tumor is in the body or the tail of the pancreas, the patient undergoes a distal pancreatectomy, which is a removal of the tail and part of the body of the pancreas, and splenectomy. And then there are several other procedures: anastomosis of the pancreas to the jejunum, anastomosis of the hepatic duct to the jejunum, anastomosis of the stomach to the jejunum, and then a phagotomy, surgical resection of the vagus nerve. So, ladies and gentlemen, please listen up, and then listen up one more time. NG tube and abdominal assessment. So, postoperatively, patients who undergo any of those procedures should be monitored for exocrine insufficiency, which is the lack of digestive enzymes to properly digest food, and insulin-dependent diabetes mellitus. In addition, patients may have a nasogastric tube that is not to be manipulated. It is not to be manipulated. Please, ladies and gentlemen, please take note. You will not touch that NG tube. If anything happens to that NG tube when you go in and you are assessing your patient, if it looks dislodged, if it does not look the same as it did the last time you were in the room, if you have any questions about that NG tube, you are going to call the surgeon that placed the tube. On page 1491, there is a safety alert, and you will know that safety alert. Pain management will be via a PCA. Pulmonary interventions to encourage lung expansion and coughing and deep breathing to prevent pneumonia and atelectasis. So, nursing management of pancreatic cancer. We are going to assess. Patients will present with non-specific clinical manifestations. Pain will be dull and intermittent, increasing with eating and movement. Jaundice, this will be first seen in mucous membranes. Fatigue, anorexia, weight loss, non-specific abdominal pain, epigastric pain, pale, greasy stools. Pruritus, first on the palms of the hands, and then it will be generalized, and dark amber urine, and this is due to the accumulation of bilirubin. So some nursing interventions for pancreatic cancer. We are nurses, so we are going to assess. We will assess vital signs. Tachycardia may be related to fever and pain. Fluid intake and output, monitor fluid volume status and prevent dehydration. The serum glucose, this will be elevated due to impaired insulin secretion. Weight, we need to monitor this because of their anorexia. Muscle mass, decreased appetite, and altered protein metabolism. We're going to monitor their pain location, intensity, and duration. We're going to assess the abdomen. Distension and enlargement may be due to ascites. We're going to look at the skin color. Jaundice may be due to obstruction of the bile flow. Pruritus, this may be due to accumulation of bile salts under the skin. And then post-operative assessment. We are going to monitor vital signs, their glucose levels, NG tube output, abdominal assessment, and the surgical site. Nursing actions for pancreatic cancer. Ladies and gentlemen, listen up, and then listen up one more time. We are going to provide intravenous fluids. Hypovolemia will occur because of third space fluid loss. We are going to maintain that MPO status until their GI function returns. NG tube to low suction, and this will decompress stomach because of the post-op distension. We will never, ever, ever manipulate that NG tube. NG tubes that are placed by the surgeon. Manipulation can increase the risk of anastomach breakdown, and we will administer insulin. Encourage coughing and deep breathing and the use of the incentive spirometer while awake. This will prevent atelectasis, improve oxygenation, prevent post-op pneumonia. Administer analgesics and antiemetics as ordered. Pain management for incisional pain and discomfort. Nutritional supplements. They will help to improve calorie input, prevent weight loss, promote post-operative wound healing. So patient education for pancreatic cancer, post-operative care, what to expect after surgery, and pain management, medication regimens, diet and nutrition, increase calorie intake to maintain weight and promote healing after surgery, signs and symptoms of hyperglycemia and hypoglycemia, production and secretion of insulin and glucagon may be impaired. Disease symptoms, progression, diagnostic procedures and interventions, and coping skills, palliative care, and support groups. And then how do I know that I've done a good job taking care of this patient with pancreatic cancer? Because of a diagnosis of pancreatic cancer, it will carry a devastating prognosis. So it is important for the healthcare providers to direct the patient to and encourage the use of support systems, encouraging the patient to be knowledgeable about the disease, treatment interventions, and restrictions is incredibly important. As always, ladies and gentlemen, thank you for your time and attention. I appreciate you all. And if there is any questions, comments, concerns, please do not hesitate to reach out.